Right, yes. I'll give an apologies and George will belay it.
Okay, thank you. Number of items under Chairperson's business. Obviously, the Minister announced on Monday that the standardised packaging for tobacco products would be introduced here as part of the regulations that came into force in May 2016. I want to just also advise members that the committee is holding an informal meeting with members of the Oireachtas Committee, and we have spoke about this in terms of a joint agenda. That will be taking place at 11:30 in room 21, followed by lunch in the private members' dining room. Can I ask members just to confirm their attendance with staff as soon as possible so we can...
What date was that, Chair, for?
It's next Tuesday. Next Tuesday.
Is it a lunch, is that what you said?
It's a meeting and then followed by a lunch.
And the meeting's who with who?
The Joint Committee on Health, the Oireachtas Committee on Health and Children.
All right, yeah.
Yeah, it'll be all right.
Just to also advise members that myself and the Deputy Chair met with the BMA just before this meeting to discuss their concerns around the unscheduled care task force. The BMA have asked specifically that and pointed out that they do not have a seat on the task force, and they are concerned that there's not enough clinical input into the process in terms of how some of these recommendations or policies are being developed. So I'm suggesting, members, with your agreement, that we write to the department to request that BMA can be added to the task force in order that the experience of clinicians working in both primary and secondary care can be directly fed into the group.
I'm happy with that, Chair, but I think also you should be checking is nursing. Is there a nurse representative there? They're equally as important. 18,000 nurses in the system play a vital role. And the third arm I would always have insisted on would have been staff side. You need a representative from staff side there, from some of the unions who are there can give a view from workforce. It's supposed to be a team game, and you can't have a team game if you're excluding large numbers. So I would happy with the BMA and a doctor, that's crucial, but also nursing and staff side.
I mean, I think it's a useful point, and we have actually asked, because there's a number of work stream groups that are flowing from the task force as well. We've asked for a breakdown of the membership of that as well, so we do need to be mindful of the point that you make. Item 3, members, is the draft minutes of the meeting on the 28th of January, which are on page 6 of the tabled booklet. Are members content?
Great.
Okay, members, item 4 is the review of workforce planning in the context of transforming your cares. Advise members that Janice Thompson and Young Todd will brief members on their paper on the review of workforce planning in the context of transforming your care. Obviously, this has been a key area of work for the committee. Dion, you're very welcome. Bursary student on placement from Queen's, studying MA course in Legislative Studies and Practice, and has been working with Janice on the paper. So we're pleased that you could come along today. You're very welcome to the meeting. The copy of the briefing is available at page 11 of the meeting pack, and the terms of reference for the review are at page 3 of your tabled pack. So you're very welcome, Janice, if you want to make the opening comments.
Thank you. Well, just to remind the committee, obviously, in June 2011 is where TYC started. The Minister announced a review of the provision of health and social care in Northern Ireland. The review panel then reported in December 2011, publishing TYC with 99 proposals for change across the range of health and social care services. Then, following on from that, the Strategic Implementation Plan was published in October 2013, and that was identified the main impact on health and social care staff as being led by the shift of activity from acute to a community and enhanced primary care setting. So that sort of sets the scene for where we've been going over the last few years. The committee has previously received a raised briefing summarising how workforce planning has been dealt with so far in the official TYC publications to date. This second raised briefing paper that you have today is specifically regarding workforce planning and is really to provide the committee with a baseline and an introductory review of health and social care staff numbers and trends in a selection of staff groups likely to be impacted by TYC. I'll just reiterate, this paper is by no means a full review of the entire health and social care workforce. It's selected groups of staff. So the aim of this briefing is really to stimulate discussion for the committee around potential areas for further investigation for your programme of work around workforce planning, in terms of, for example, the numbers, locations and patterns of work of various staff groupings in line with the implementation of TYC. Now, obviously, it would be impossible today to look at the paper in full detail, and it's really provided as a reference source as the committee proceeds with this programme of work. But Dion and I will now go through some of the main points and trends for the various staff groups. I wouldn't recommend that you necessarily try and follow through the graphs or whatever that I refer to. Probably best to look at those in your own time, but we will bring out some of the key points. Section 3 of the paper provides you with a series of trend graphs and analysis of selected health and social care staff groups, using figures taken from the official Northern Ireland Health and Social Care Workforce Census. Now, that workforce census does not include independent contractors such as GPs, and information on these staff groups is covered in Section 4 of the paper, which I'll come to later. So, looking at Section 3 of the paper, overall, from the year 2000 onwards, the following staff families generally show an upward trend in numbers right across Northern Ireland: qualified nursing and midwifery staff, medical and dental staff, professional and technical staff, social services staff and ambulance staff. The administrative and clerical staff, they showed a total general increase up to around 2007-8, but this increase has since levelled off. So it's a general overall upward trend really from the year 2000 in those particular staff families. Now, Dion, I'm going to hand over to Dion, who's going to describe a bit more detail.
Okay, so a closer look was taken at the period 2008 to 2014 at selective staff groups within these staff families, and this shows variations within the general overall upward trends depending on staff group and with variations between trusts. I will now highlight some of the variations noted across the time period 2008 to 2014. For qualified nursing and midwifery staff, district nurses and treatment room nurses show a general decrease across Northern Ireland. This was queried with the department, and the responses state that it is difficult to comment because the trusts have recoded some staff at different times under Agenda for Change, for example, to the specialist nurses grade. Acute nurses show a mixed picture of increases and decreases across trusts. Mental health nurses have remained stable in number across Northern Ireland, but there are varying increases and decreases across trusts. For medical and dental staff, consultants and foundation senior house officers, there have been general increases across all trusts of varying magnitudes, and specialty specialist registrar GP trainees have seen a general decrease across Northern Ireland with a small increase in the Northern Trust. For professional and technical staff in all staff groups looked at, there was generally increases across trusts with variations between these trusts. The groups looked at were dietitians, physiotherapists, radiographers, speech and language therapists and pharmacists. For social services staff in all staff groups looked at, there were general increases across trusts with variations between trusts including some decreases. The groups looked at were social workers for child and family care, hospital, elderly, learning disability, mental health and social care staff. For administrative and clerical staff, total numbers of this staff family show an increase from 2000 to 2007, followed by a steady decrease. There have been steady decline in total numbers in grades 1 to 4 across all trusts from 2008, but there has been an increase in total numbers in bands 5 to 6 since 2011 in all trusts. As stated earlier, the trends looked at in the paper are for a selection of staff groups and not a full review.
Thanks, Dion. In addition, there were, as we looked through the graphs for specific trusts, what you have in your paper is tables of percentage increases or decreases across the trusts for each staff group. There are graphs behind those. We haven't included those in the paper, but they are available if you wanted any of them. But they threw up several anomalies here and there, and several questions were put to the department for clarification of certain numbers and trends, and Ray's received a response yesterday afternoon, so these will be reviewed and the paper will be updated as soon as possible. So staff numbers and trends across Northern Ireland as a whole and within the trusts, of course, is only part of the story. The key to the success of implementing TYC, as the committee is already aware, will be in the changing roles and locations of certain staff groups, with increasing treatment occurring in primary care and community settings. So pertinent questions that perhaps could be further investigated are, do the increases and decreases in different staff groups over recent years support the direction and implementation of TYC? Is the current information collated by the department on the workforce going to be sufficient to monitor the implementation of TYC in terms of the workforce? That's probably a question for the Regional Workforce Planning Group. The committee's previous work on waiting times and cancelled clinics has revealed that in some areas the usual information gathering routes are not always sufficient for its scrutiny of a particular policy direction. So the committee may just wish to think about the sort of information that it might require. Moving on to looking at section 4 of the paper, it is evident that gathering recent or current information regarding staff numbers not covered by the HSE workforce census is difficult, for example with regard to GP practices. The total number of GPs and the current number of GPs and GP surgeries is known, but beneath that level, to actually gather information about the number, say, of nurses or administrators that these independent contractors employ does not appear possible without contacting individual GP practices. However, prior to the establishment of the Business Services Organisation, it appears that a directorate called the Family Practitioner Services Directorate did publish more detailed information in the past about general medical services, dental services, ophthalmic and pharmaceutical services, with its last statistical report published in 07-08. And those statistical reports did seem to have a fair amount of detail on the numbers of staff employed within the primary care sector. So another possible area for consideration for the committee as it goes into its workforce planning work is this potential gap in recent and current data about the numbers and locations of some various groups of primary care staff, those that are employed by the independent contractors, because they are no longer obliged to collect that data centrally since the new GMS contract. Well, it's quite a number of years old, but since the GMS contract, that information doesn't seem to be collected. There's further information in the paper on that. In order to provide the committee with the most up-to-date position regarding workforce planning in connection with TYC, Ray's requested an update on the work of the Regional Workforce Planning Group and an update on the workforce plans of each of the local commissioning groups. Again, we received the response from the department yesterday, and this will be reviewed and the paper will be updated for you as soon as possible. But I believe we are planning to hear from the Regional Workforce Planning Group. So thank you for listening. As I say, we rattled through some of the key points there, but there's sort of no other way to do that with this sort of paper. It's really there as a reference source for you and a starting point for your work programme. But I'll be happy to come back with any further research as needed and to take any questions now at this early stage of your work in this area.
Thank you both. It's useful tool for us in terms of just starting the process. But obviously, key to this, I think, will be whether the direction in terms of workforce planning supports the policy shift. I think that's going to be the piece we would want to drill down, and I think also the policy direction and the requirement that there will be a specific type of staff required, and quite often it can simply be about recruitment as opposed to the conversation of who do we need to recruit. So I think that's part of it. But just, and I know that this will be a question to the department, but in terms of I think there's been 2 attempts at workforce planning over a number of years. Is there any sense in your research that recommendations have been implemented?
Well, as I say, I asked for a full update of the Regional Workforce Planning Group's work, and it was established to take forward the proposals in TYC, and I'm just skipping through the department's reply here. The Regional Workforce Planning Group, the Department states, has now completed its interim phase of work and a planning framework has been developed, so I'm sure they will be able to update you on that. The implementation of this framework will be led by the Department and primarily taken through the Regional Workforce Planning Group. The original workforce planning figures provided in the local commissioning group population plans, which are a few years old now, the Department advised me that they were very high-level workforce statements and should be regarded as extremely indicative, and they will be subject to more detailed refinement as these reform plans go ahead. So it's a simple answer is to your question that it all seems to be ongoing. There are other workforce review in progress that I requested an update on, and they have provided some updates on the review of the nursing workforce, the review of the medical workforce, a medical workforce planning subgroup, a radiology review and a domiciliary care workforce review. But I haven't had a chance to go through that information yet, and I will update the paper with that. So there are a number of additional reviews ongoing, which will all feed in, as far as I can gather, through this regional planning group eventually.
I mean, one of the clear challenges in this is the reduction of district nursing and health visitors, particularly in line with a so-called shift left policy direction. You know, and there was to be a piece of work that the department, I thought, were to complete by the end of last year around normative staffing levels. I don't know if they have come back, particularly in terms of nursing. I don't know if they've fed that back to yourselves or...
Well, one of the questions we did ask them was regarding the health visitors. Do you want to do that? Do you want me to? Right, okay. I had queried what appeared to be a decrease of around 9% in the numbers of health visitors, particularly in the Belfast Trust, against the general Northern Ireland increase, according to the workforce census. The Department have replied that the figures seem to vary over the years due to whether or not student health visitors were included in the total number or not, and they have been included in the 2014 figures but excluded in earlier years, and it's preferable apparently to include them because they are qualified nurses with their own caseloads. And they have provided some additional figures, which is a more direct comparison, including the numbers of students. They also have advised me that there's an increase in the number of health visitor training places, 37 extra places in 13-14 and 61 places in 14-15.
Yeah, but if it was a 9% decrease, it's hardly...
But they're explaining that, that's what I'm saying, they are explaining that it's terminology as opposed to... it's how the numbers were calculated in their workforce census. I queried that figure and the response. That's how they've come back with this response, that it's to do with whether or not the student health visitors were included. So I have a new set of figures which will come to you, you know, when I update the paper. So I only received these yesterday, so it wasn't possible to get them to you.
Absolutely, no, I appreciate that. And just finally for me, see in terms of the point that you made about the gap almost in the recent and current data. You know, the issue about, and it's in your report about the GMS contract and GPs not required to inform the HSE or the department about the number of staff they employ. I mean, how you know, how do we actually get accurate data then if we have a gap like that?
I suppose all, from my point of view, that to me, when I start to look at, well, how do we find out, you know, about the staff then that aren't covered in the workforce census, the independent contractors? The BSO hold a certain amount of information, and when I looked at their website, I noticed that up to 2007-08 there were publications produced by this Family Practitioner Directorate, quite detailed statistical publications covering GPs, dental surgeries, pharmaceutical services and ophthalmic services. But then there's a gap after that, and as I say, it was the department then advised me that under the GMS contract, the independent contractors were no longer required to produce this information. So again, it's probably a question for the regional workforce planning group. Are they collating this data in some other way? How are the GPs feeding their staff numbers into the overall picture of staff available in primary care to take on the work? And well, I think we've heard, and I have heard on occasions that the GPs are concerned about the workload coming their way. I don't think that's news to any of us here. So it is. I mean, as I said before, when we've research have looked at things for the committee recently in terms of the council clinics and waiting times, the official routes of information that are collected routinely sometimes haven't been sufficient for the scrutiny you wish to place on this. So again, maybe this is another area where additional information gathering could be required for the committee's scrutiny.
Okay, Janice, thank you. Kieran, first.
Thanks, Chair. Thanks very much for your presentation. I appreciate there's a lot of work has gone into that. Just a couple of simple questions. And is during your work, was there any evidence that the views of the staff having been sought in relation to transforming your care, as this was a major commitment within the strategy? I mean, in other words, was the ordinary staff on the ground asked what was going on in relation to?
Oh, certainly. In terms of workforce planning, I think actually that was an area that was covered in the first briefing paper that I gave to you. But I think there might be something in the introduction to this paper. Yes, in the introduction to this paper, section 1, there is a paragraph you'll come across saying that although the responsibility of workforce planning rests with the department and will involve the regional workforce planning group, it includes continuing engagement with staff, professional bodies and staff side organisations. So it's certainly something that the department have signed up to in terms of consulting with staff along the way. But again, hopefully the regional workforce planning group will be able to give you more information on how they're actually doing that whenever you see them.
Yeah. The other thing is, what assessment can be made of the overtime pressures within any particular professional specialism or job role to get a fuller picture of the pressures on staffing? I mean, I think it was only this week where we heard that some staff who are changing over shifts, for instance, have to work longer. You just can't walk away from a patient, and they're going to claim more overtime funding. Was there any evidence of that?
Well, I think in terms of this paper, it's placed at a much higher level in terms of getting an overall picture of staff numbers and trends. If the committee decides to perhaps look in more detail at specific groups of staff, that's certainly the sort of areas that you could look into. You know, how many hours in practice are certain groups of staff working, but that would take it into a much deeper sort of level, focusing on very specific staff groups.
Right, okay, thanks.
Thank you, Kieran. Michael?
Okay, thanks, Chair. Thank you, Janice, an interesting report. And I really haven't had time to digest it, so I'll no doubt ask questions on another date, at another time. Demis, you're talking about whole-time equivalents. What about head count? Does head count match these trends?
It does, actually, yes. We had the head count originally in some of the graphs. Do you want to answer that, Diana?
We actually just decided to take some of those graphs out because we thought, like, we did this before, it was about 102 pages long. So it's all in there and it just tends to follow exactly the same pattern as the full-time equivalent.
It's the use of bank and agency, for example, in nursing, and also the various bands in nursing as well. Are you comparing apples and oranges?
Well, the
like
bank, I don't think the bank are
I don't think they are.
No, they're in the...
Search that for you, but
Yeah, you got the... Yeah, we do. It tells you... Actually, in the workforce census, it tells you exactly what is covered, and I don't think bank staff are covered. No, they're not covered in the totals. These are employees of the trusts
because
that the workforce census
you know how it
covers.
works. If you've got money, you can afford to employ bank and agency. If you don't have money, you can't, and therefore huge pressures fall on them.
Yeah, we focused on a whole-time equivalent because we thought it'd give a better flavour of
But you do have
availability.
you do have the head count, and you do have bank and agency figures there if we need them.
We have the head count. We wouldn't have the bank and agency staff not prepared for this particular
That would be the
paper.
trust
That'd be
would provide that.
it'd be a separate piece of work.
Aye, okay. Now with this, in an exercise like this, we are at a particular point in time, and we're looking to travel, and it's the shift left move. So therefore, the workload at today will have changed, hopefully dramatically, during the period. So the first thing you need to know is what's the time span to take you to where you want to go, and therefore then what is the workload and how is that going to vary. what work has been done on that to tell you what staff are going to be needed in what disciplines and what professions at what grades? So that this is 2015, say in 2020.
Well,
Because you now have, within our paper, there's an £86 million cut to hospital services, presuming that TYC is going to deliver on the ground. It's that type of exercise. Have you done, or has anybody actually told you what the model is going to be like in 2020 or in 2025?
I don't think that picture is there yet. I think that's the work of the Regional Workforce Planning Group on the departmental side. I mean, certainly the earliest figures that we saw on the committee were the local population plans and the very high level indicative staff numbers decrease. I think was that they were aiming for in the trusts and the local population plans, but they are very indicative figures, and the department have highlighted that again. So the work you're talking about is really the work of the Regional Workforce Planning Group, and as I say, they have provided me with an update of that, and I will include it in a new version of this paper, which you will get, so you will be able to update yourselves with what they've done so far. As I said, they have produced this framework. Trying to see if there's anything else I can pull out of it to highlight to you today. They refer to 4 system-wide initiatives identified: reforming outpatient pathways, reablement and acute. The Health and Social Care Board is prioritising the first 2, which is outpatient and pathways. Reablement is already well advanced. So the mobilisation of these system-wide initiatives, the department says, will provide a significant opportunity to reshape the workforce in line with new service models. So I would like to think that the Regional Workforce Planning Group will be able to tell you an awful lot more about the work they're doing and progressing, because it is all in progress.
When you're talking about reshaping the workforce, we need to know reshaping it into what? What is the shape of the workforce?
Well, yes, I mean, that's something I have not seen.
5 years' time or in 10 years' time, because that will have profound effect on the way service is delivered.
Yep.
So if you have more nurses in the community, you'll have less in hospitals, so therefore you'll have fewer beds, so therefore you'll have fewer hospitals, and it's that type of...
I suppose that's what I'm saying. The numbers are only one part of the story. It's where the staff are working and what they're doing, and the roles is the other part of the story. But even as this paper has shown, there are gaps in the current primary care data, or certainly gaps that are certainly information I couldn't get access to. And I did contact the RCN, who you'll see a reference in the paper to that they didn't know, they didn't have numbers of treatment room nurses, say, that were working with GPs, employed by GPs, practice nurses. So, I did try quite a few avenues to try and fill that gap before the paper was written, but...
just getting back to bank and agency, have you any idea how many bank and agency are employed at the current moment?
No, I couldn't answer that question today because it wasn't part of this paper.
That would be a very useful...
It could be another piece of work. The committee can consider that if they feel it would be useful for taking forward the workforce planning. It can be a separate piece of research that you can commission.
Okay, thank you, Michael. Fergal, thanks.
Yes, thanks. I'd just like to follow on from Michael's point. Actually, I don't quite know how this would be presented, but in my head I see it almost like an overlay on what you're doing, because for me the bank and agency thing is crucial, because I think they spent 50 million last year on bank and agency. So, but not just in terms of full-time equivalent or whatever, but what functions are they performing within the system? And do you subtract what you've got from what that would additionally provide, or do you overlay it? And does that then point to the nature of the prop up the bank and agency, or does it? And then the further overlay is, do the policy directions and their timing fit with the dips or the increases in the graphs as presented? I think there is additional work, valuable work, I think really core to what it is we're doing. And it's not just a drill down of the overall numbers, it's got to be the function within banking agency, to what degree each trust is doing that as well. So, but this is great.
That's, that's, I mean, already, I suppose this paper has served its purpose in that it's starting to stimulate
yes, absolutely.
the
this is
thinking,
great.
you know,
It's great.
for
It's
your
good to see the way that it's
workforce
presented, and it's
work.
clear, but it is pointing in the direction
Yeah.
of further questions. Thank you.
Thank you, Virgil. Paula?
Thank you. Thank you. I'm just looking at the social work part, as you would know, would be doing, and also the allied health professionals as well.
Yes.
And the different increases amongst the trusts. The South Eastern Trust, the major increase in social work there was that due to the reconfiguration of the trusts, or
I can check, what page are you on there,
it
please?
would be the graphs would be
Oh, yes,
from 38 to
Yeah. Yep,
44, whatever it is.
Yeah, 33, yeah.
Because all the South Eastern Trust, their increase in even for the likes of hospital social work was
Oh, yes.
96%.
Yes.
Massive. Was that due to the?
So, it's
Yes,
if
you
you
can
see
take
the
that.
the whole time equivalent there, it's
Yeah.
actually because the numbers are so small. It's going, it is basically doubling, but it's going from 11.5 full-time hours to 22.2. So
Yeah.
just because it's quite small numbers, I think is why it's such a huge jump.
That's particularly the hospital
Yeah.
social work
Yeah,
numbers.
sorry, that's
It just amazes me how, but even for that to double,
yeah.
you know, what is the difference in the need between then and the need between now, when we don't see the same increase in other? If you just look specifically at hospital social work, I was just wondering whether it was because of the reconfiguration of trust and of agenda for change and all those, did that factor into that? I don't
So
know.
that's not one specific. I can certainly put that question. There was, as I say, there was a series of questions that,
I mean, every one of the South Eastern ones, if
that
you
I
look at all the
put
social
to
work
the
increase.
department on the various graphs, and that wasn't one particular question. But we can certainly, if there's questions come out of the graphs, feed them through
if
Catherine,
you-
and we can chase them up.
If you look at the graph on our page 43 and your page 33, which is for mental health social workers, which has increased almost everywhere, which is great. But if you look at the South Eastern Trust, there's an increase of 423%. You know, so it's just why we have such a massive, because surely the need wouldn't have changed dramatically. And that yet when we look at the allied health professionals, there's not, it seems to have stayed, it's with the same trend amongst all trusts, other than dietetics in the South Eastern, which seems to have jumped up massively. Just
So, some of the difficulties with when you start to look at the groups of staff is that over the years, definitions of staff have changed, and the department did advise us of that. There's when the agenda for change codes came in, there's definitions of things of staff have changed. Now, as I said, we did go back and put a series of questions to the department based on some of the higher level anomalies that came out. We didn't go into any of those real detailed specifics at this point, but we certainly can do if you want to know anything specific about any of the trusts. We can certainly go back and ask for more detailed explanations. We have got detailed explanations of some of the anomalies which will be coming to you in the new paper, for example, regarding social workers generally, the total number across Northern Ireland. There was a big jump between 2007 and 2008 in the overall total numbers, and we did ask the department about that specific overall increase, and the response was that there was two factors at play there. Firstly, the 2007 workforce census did not include staff graded as home helps, but for the first time the 2008 workforce census did. So secondly, due to agenda for change and regrading of jobs, many workers who were previously coded to what was called the ancillary and general terms group were recoded to fall within social services. So there was two factors at play in that big jump between 2007 and 2008. But so it's actually, when you start to look at these different groups of staff, there's an awful lot of factors come into play in terms of explaining the increases and the decreases in various groups. But as I say, if there are any specific groups you're particularly interested in, or any anomalies you particularly want us to investigate further, we will do so.
I can understand that with the first graph we have on social services is social services staff, and
It's
that
overall.
includes the whole family.
That's the whole family, yeah.
That's fine. But then the other specific ones are actual
Yeah.
social workers, which probably will maybe also be social work assistants in that as well, which is fair enough. But it just seems a really big.
There certainly
increase.
are variations across the trust, and we can pursue them further if you want.
And also to do with the per head of population in trusts and trust size, you know, the variances.
We could have gone on forever.
I know. Just that would be interesting to
Yep.
see right across all staffing. You know, what are the trusts? Where are they putting the money into? Is it a specific grade, or is it a specific?
Yeah. Well, I'll certainly speak with
health
Catherine
professional?
after the meeting, and if
Really
you know, we
interesting.
can look at what further areas are
Really,
worth
all
digging
trusts
down
should
into.
be pretty much the same. They should have the same. But I mean, I was looking at hospital social work because that's where I come from, and you're kind of thinking, you know, if you've got a big acute hospital, you're going to have, you know, a higher social work input there, because they're essential for getting patients discharged from hospital. You know, when you look at some of the trusts, why have they got such a massive amount of hospital social workers? So really interesting.
Thank you, Paula. And Rosie?
Gurmagri Caherly, and thanks very much. Very interesting report. Loads of information, food for thought. I was just wanting to just explore a wee bit further the whole issue around the lack of information on GP surgeries and GP practices, I suppose. What do you think? Is it just that nobody has tried to go around them all? Does it seem like too much work to try and gather that, or is there a?
I'm not
reason?
saying the information isn't there somewhere, but it's
Yes.
certainly not collated centrally anymore by the department or the business services organisation, as it would now be responsible for that. And certainly when I approached, I also approached the BMA, the Royal College of General Practitioners. It doesn't seem to be. It doesn't seem to be information that's readily available without going to, because under the new contract they are independent, contractors. They're given their sum of money, and how they operate the GP practice and who they employ and how many practice nurses or administrators or practice managers or whatever is down to them as independent contractors, because that's part of the contract. So actually getting hold of that information probably would necessitate that, and maybe someone has done it somewhere and I just haven't found it yet.
Yeah, it just strikes me that
Maybe someone watching this somewhere will have done it and email me.
Yeah, but if you're looking at transforming your care and the GP service is going to be central to that, and it just strikes me that you would want to have that information in the context of, if you were looking at maybe trends, if you're looking at results, or if you're looking at outcomes, the size and the flavour and maybe the richness of service in one particular surgery as opposed to another one might reflect medical outcomes and life outcomes for people. So it seems to me it might be useful to try and get that information. I don't think it would be too hard, but maybe I look at things too simplistically. I'm just thinking there's a database of GP surgeries sitting there. You could draft a pro forma in 5 minutes, so it'll be a tick box. And just
Well, as I say,
email it
up
out.
till a number of years ago, it seemed that sort of information was more routinely available when collected by the family practitioner directorate. I have no real familiarity with the work that they did until I, read it in connection with this paper. And certainly in those statistical reports, there was things like numbers of GPs per practice, numbers of practices, number of GPs in those practices. I mean, for this one, I was particularly coming from it at the point of, yes, we know how many GPs there are in Northern Ireland, but do we know how many treatment room nurses they're actually maybe employing, how many practice nurses they're employing? Because that's pretty crucial for delivering some of the work on the ground. Do they have a specialist dietetics nurse or dietitian, or do they have a nurse capable of running a clinic for diabetes or something? If that's going to be run in the community, so that sort of level of information. Now, again, I'm not saying it doesn't exist, but perhaps, they again keep referring to the Regional Workforce Planning Group. Maybe they have access to it. Maybe they are looking into that. I wouldn't like to say they're not, because I don't know.
Okay. Well, here's just one wee example of what I'm talking about. I live in West Belfast, and there are high levels of health issues. It's got high levels of all of the indicators in terms of unemployment for health and education outcomes. So it would be worthwhile having the information. But my doctor surgery, it's walk-in, and you will see the doctor. I'll just go and I will see the doctor. People very close to me have different doctor surgeries, all within the same area. I can get an appointment for 2 weeks. So to me, there's something not right about that. There has to be a reason. So I'm only flagging that up as an example. Can I just move on to the district nurse statistic and why do you think that has dropped so much over the years?
I'm just
I'll
finding
say
where we
it's
are
on
here.
page 13 of 23 at the top,
Yeah.
or page 13 of your paper.
Okay. Well, there was just, did we get a response?
Yeah, we did.
Okay, yeah, we did. Whenever I query the decrease in the district nurses and treatment room nurses across a general downward trend across Northern Ireland, the departmental statisticians have advised me that it is difficult to comment on this because the trusts have recoded staff when the agenda for change grade codes became available, and at different times, for example, to the specialist nurse grade. So, but again, I suppose it still begs the question, if we can't compare the numbers over time, how many of these types of staff do we have over time? You know, if they've changed the codes over time, then it's hard for us to produce the graphs any differently than what is reported in the census. But there may be other groups of staff that then should be added in there, and that's what they're telling us, that it's difficult to comment on this because they've been recoded. Again, it's a question probably for the department or further investigations, workforce planning. Yes, okay, it looks like your numbers of district nurses and treatment room nurses, but these are the ones employed by the trusts. These are not the ones employed by GPs. Though there would be very few district nurses employed by GPs, they would be trust employees. It would be more just treatment room nurses, practice room nurses, maybe nurse practitioners. I know our health centre has a nurse practitioner. You know, again, I suppose it's a question of how many of these, it's back to the roles really. How many staff do you have doing this sort of community role, even if they're called something different than they were 5 years ago?
Yeah, because I would expect that in the rollout of Transform Your Care, as it goes further down the line, you'd need more district nurses. I just would imagine that, but maybe I'm missing something. But you know, maybe then the statistics, maybe the information isn't as well. It's not telling us what the picture really is, and we don't know.
Yeah. Well, that's, I mean, if there's another type of nurse doing the role that the general term district nurse used to do, for example, a new type of specialist nurse, but working in that sort of thing, then that's what I suppose the committee does need to know to be satisfied that those staff do still exist or are on the ground, but by a different name. And that's what is tricky to uncover in this sort of exercise. You know.
Yes.
Does that help?
No, I understand the restraints and the difficulties you have.
I know Agenda for Change was a nightmare at the time, trying to manage that as staff were regraded and so on and so forth. As we collapsed from 19 trusts down to 6, then we went from 4 boards to 1, and that caused a whole, complete confusion, but it was difficult just to keep tab, and that lasted for a couple of years. Yeah.
So as I say, the staff may well still be there, but if they're called a different name, they're not maybe being counted under what is being counted under treatment room nurses. District room nurses may look like they've gone down over time.
They're somewhere else.
But the department are advising me that because of the recoding, they can't really comment, as to whether that is actually the case or not. But I suppose the thing is, are there staff still doing that role by another name? You know.
Yeah.
That question can be answered. The department can answer that question.
Well, that's again for a further piece of work. If they certainly, when I asked for why the treatment room nurses or district room nurses appear to be going down. Their response to me was it was just difficult to comment on that statement because of the recoding of staff. So maybe I need to ask a different question.
Okay, thanks.
Okay.
Thanks.
Yeah, just
Very
to
well
in on this point, because
Yeah.
you know, if information isn't being collected, and we've got to marry some of these things together even now in this discussion. I mean, I've asked questions about how much on a daily basis does the system have knowledge of queues at GPs. They don't know and don't collect that data. We don't know about, as you're saying, you know, and anecdotally, we know that there are major waiting times at GPs. But it seems to me, with the lack of gathering information, they're almost dissociating the GP function and that front door from the overall system, and then making decisions within the hospital side, which could be resolved if they were to look differently at the GP side in terms of the staffing, knowledge, etc., etc. And I assume you're right, Michael, that they probably have a lot of post-match analysis in terms of how many people were treated last year or whatever. But we don't know how regularly that information is gathered, and if they're making resource, workforce, or any other decisions based on the information that they are gathering. So all of this is just pointing to a larger body of work, and trying to get focused in on what the problem is. Thanks.
Okay, thank you, Fergal, and thank you both.
Thank you.
Obviously, it's a useful tool and a useful step forward for us. I think it would be appropriate as well that we would write to the regional workforce planning group around the issue of the GP's contracts, and just inquire as to how that information, is it being collated, where is it being collated, how is it being collated, even in advance of them coming here. And then we would look forward to your response from the department being fed onto the next updated version. Okay, so thank you
Janice,
both.
you're not with the department, you're from somewhere else, is that right?
From here, Northern Ireland Assembly researcher.
Oh, you're the semi-research department, I didn't know that, yeah, okay.
Okay, thank you both.
Great.
Okay, members, moving on. Item 5 is the Commissioning Plan Direction 2015 Departmental Briefing. Page 56 of your meeting pack, and there's a copy of the Commissioning Plan Direction at page 67 of the meeting pack, and there's a paper prepared by the clerk which is page 5 of your tabled items. Folks, you're very welcome. We have Mr. Mark Lee, Director of Healthcare Transformation, Ms. Fiona Hamill, Director of Service Delivery, and Ms. Jennifer Mooney, Healthcare Transformation Directorate. So I'll hand over to yourself to make the opening comments, and we'll open up to questions.
Thank you, Chair. And good afternoon to everyone. So just, I'll take the opportunity to make a few comments on the approach we've taken to the draft commissioning plan direction, which we've shared with you, to summarise some of the key changes to the standards and targets. In doing so, it's obviously important, and I know the committee will hold this in mind, to think about the financial context in which we'll operate in. The committee are very well aware that 2014-15 was a particularly challenging year for health and social care, and that 15-16 is going to continue in the same vein. As a consequence, we've had to think very carefully about the targets and standards that are set in here, while a plan to secure financial balance has been developed. And that means the finding of substantial savings by the department and its arm's length bodies, and means that the department's budget for 2015-16 does not allow for the funding of any new service developments. In that context, we've always had to be realistic, but also remain challenging in what we ask the health and social care system to deliver, and the draft commissioning plan direction reflects that, and the fact that we've had to scale back some targets and remove some others. Even having done so, I would say that I think it will remain challenging for the health and social care sector to deliver the targets and the standards that are set out in the direction. Just a few comments on the detail of the draft direction itself. You'll notice that it's considerably shorter, so we've helped with the load of your reading there, but the details on the key services to be delivered regionally and across each of the 5 LCG areas are still there, and there's still the requirement to demonstrate how services will meet the assessed needs of populations and how ministerial targets and standards will be met. So the 2014-15 CPD, 7 strategic priorities, we've now combined these into 3 core themes around improving and protecting population health and well-being, reducing health inequalities, providing high-quality, safe and effective care, listening and learning from patient and client experiences, and ensuring high levels of patient and client satisfaction, and finally, ensuring that services are resilient and provide value for money. As the letter from the Minister highlights, 14 targets have been rolled forward from last year's commissioning plan direction, 12 have been revised, and there are 4 new targets which we're proposing or considering to add in. So 10 of the targets from previous year have been removed. There are, as the committee will have noted, a small number of targets where we're still working on the exact detail of the number to be put in there. And I hope to finalise that detail by the end of this week, or certainly early next. Of those that are continuing to roll forward, that's because we continue to place a lot of importance on the achievements of these targets, and the Minister wants to see real progress in achieving targets on things like emergency department waiting times and cancer access times. Some of the targets that have been revised, some of them we've pushed up. So, for instance, direct payments and stroke, where we think performance is strong and we can go further. And the Minister is also very keen to see a significant reduction in the number of cancelled outpatient appointments. In some other areas, we've had to recognise the budget constraints that we're under. And again, as the Minister's letter sets out, target levels for outpatient assessment, inpatient and day case treatment, and access to allied health professional services have had to be reduced to reflect that. None of us would wish to perhaps take that approach, but we need to set realistic targets for the financial context in which we find ourselves. Similarly, I should point out that the lack of funding has meant it's been necessary to remove the current target for access to specialist therapies. We will, of course, keep that under review, as with all the targets, and if additional funding becomes available in year, we would look to see whether we can change that position. We've continued to have the focus on transforming your care and reform within the system, which becomes even more important in financially constrained times, as does the focus on moving upstream to population health and well-being, where we've included targets. Good progress has been made on the integrated care partnerships and progress there. So we've removed those from the direction to focus on the outcomes that the ICPs are trying to achieve, rather than the process of creating the ICPs themselves. The only other thing I'd flag, Chair, is just to highlight, given the financial challenges, we've set some of the targets to try and ease some of the pressures there. So we've been very clear that we want to see further reductions in the length of hospital stays, significant reductions in the number of hospitals cancelled appointments, and the delivery of at least 20 million in efficiencies from prescriptions. So those are challenging targets to try and make the HSE and the system more efficient. The final point to make is to remind the committee that, as well as the commissioning plan direction, there is an indicators of performance direction which sets out the data that we'll continue to collect, and even where we've removed targets from the commissioning plan direction, we'll continue to monitor performance through the indicators of performance direction. I hope that's useful as a brief summary of the approach we're taking, and myself, Fiona and Jennifer will do our best to answer any questions that you have.
Okay, thank you, Mark. I suppose in terms of transforming your care, can we maybe get clarity now on how much exactly has been shifted left?
In terms of the
terms of
quantum
money?
of funding that's been, so I know we've written to the committee on that previously, setting out the figures in terms of the shift left, in terms of three elements of this. One of them is the services that have been stopped in hospitals and moved to community. So, for instance, mental health services. There are also some areas where we've either created new services in the community or have invested in community services rather than hospital service. I don't have the figures in front of me, but we have provided them to the committee before, and they...
Well, the last time that you were in front of us, we were told that it was 25 million. But then there were some, you yourself had indicated that might not be accurate.
So I'd said I thought there might be more to say in terms of how much had shifted left and the correspondence we provided, as well as giving the, if it was 25 million, the figure from the stop in hospital services, then also provided that broader picture in terms of additional investment in community facilities rather than hospital facilities. You know, I don't have the figures in front of me, but those additional numbers were attempting to demonstrate a broader shift left than just the 25 million figure.
But the 25 million had been identified for the 13-14.
Mm-hmm.
So what has been shifted 14-15 or 15-16?
Again, so there were I'm working from memory here on what that letter says. I think there were a few things in there that it suggested had been, and there were continuing savings from the move of mental health services.
But you see, I mean, would you not agree that it's really irregular to be discussing a commissioning plan and setting targets when we don't even know what has been shifted to date on the key policy direction?
Well, that letter sets out what has been shifted to date.
Yeah, it said there was 25 million and 13-14.
Are they not 14? We wouldn't have.
No, it was
14.
It was 13-14.
Yeah.
And I mean, the question is then, what is anticipated? I have to say, Mark, I find it really irregular that we can't get an accurate figure. How are we supposed to set policy direction if the key policy that we've all collectively signed off on and we don't know how much has been shifted?
So I'm sorry, I don't have the letter in front of me because I wasn't expecting to have this particular discussion now. But that provides all the detail. Obviously, until we get to the end of the current financial year, we can't give you a clear position on.
But Mark, transforming your care is critical to the commissioning plan.
Absolutely, yep.
Well, the obvious question is, how much have we transferred?
So, and I think that the broad answer to that is not enough, which is why there's still a target in here to continue to transfer money from the acute side into primary and community services. So, again, I don't have the figures in front of me.
But the department, you know, Mark, are in charge of this.
Mm-hmm.
You know, you should have a figure. You should be coming to us with that figure. We're discussing the strategic direction and going forward, and we can't even get an accurate figure on how much has been shifted.
Well, the accurate figures are those that we've written to you on previously, and again for this current year, we won't have final figures until we are at the year end and can take stock across that. I mean, again, I can go away and write further on this issue, but I'm not sure there's much more to say than in our previous letter.
Well, then, you know, okay, you're in charge here. Is it 25 million? Is it more than 25 million? Is it less than 25 million? Who, if it's not yourselves, has the figure?
So the position is as set out in the correspondence to you.
But that was 25 million, Mark, and it was 13-14. We'd asked what was anticipated in this budgetary round. We're asking for an accurate figure, and we're not getting it.
Are you asking for the figure for 15-16?
Yes. I'm asking you to date, in terms of the money, that the 83 million that was to be shifted left, that everybody signed up to, and the 70 million transitional funding that was needed to do that, how much has been shifted left? And the only figure that we got to date was 25 million. And then we were told it might not necessarily be accurate. So I'm asking the question, how much in transforming your care has actually been shifted from acute to community or primary?
So for the end of 14-15, I think the current figures suggest it will be around 27.5 million.
So that's 14-15.
Yes, yeah. Again, we won't be able to finalise that until the end of the year. That's the cumulative figure over the entire period. So up to the period to 2014-15, there will have been a total shift of 27.53 million.
Do you see even that 27.5 million? We're now realistically saying that there's only, what, 2.4 million that has been shifted in this current budgetary round?
Correct, in terms of the shift out of hospitals into communities, and that reflects, obviously, as the committee know, the unsuccessful bids in year for additional funding for moving services across to...
But how are we supposed to have confidence in a system that is about shifting, keeping people out of hospitals, focusing on primary and community, if there's only 2.5 million shifted in this budgetary round?
Yeah, and that's a reflection of the financial circumstances in which we find ourselves. I mean, the department will continue to do everything it can to find funding to safely move services into a community and primary setting. But as the Minister said, we must have the transitional funding to allow us to do that safely. And if the transitional funding isn't available to do so, then we won't make decisions that put safety at risk.
Well, it's about prioritising. You know, it's about prioritising, and all of us collectively have signed up to this concept of shift left. It's not delivered, and it's not delivered in that commissioning plan, as far as I can see. And to be told to only 2.5 million has been shifted. How are we? It's no wonder that we have a crisis in our emergency departments or our GPs struggling, and all of the struggles on the system and pressures on the system. 2.5 million.
Mm-hmm. Again, I can only reiterate. Obviously, the financial challenges are key to this, but the department remains focused on delivering that shift left.
And you see, in terms of the commissioning plan, now you're talking about the department allocated the money. We talked about the money that was allocated towards a new service delivery model, but you talk about the availability of transitional funding. Who's responsible for making that available? Where did that come from?
The transitional funding. So either the department has to find it from within its own budget, or it has to bid through it, which has been the previous approach through the various monitoring rounds from central finances. And we've made various bids for money over the last financial year, which have not been successful.
Well, you know, I reiterate, I don't think it augurs any great confidence in the system. And its priority in terms of its strategic direction. If all that we've seen shifting is 2.4 million, I really don't. But I'm going to move on. Kieran.
Yeah, Chair, I mean, I'm here what the answers were to the Chair, and I really must say I'm disappointed, because if that's the rate that Transforming Your Care is going at, we're never going to get it delivered, and our patients will lag behind and suffer. So what you've been saying to the Chair is very disappointing. But my question is in relation to the targets dropped for 2014, and particularly the target for mental health and learning disability resettlement. You state that it has been removed from the commissioning plan, which was to resettle all the clients by March 2015. The department's briefing paper states that the majority of clients have been resettled. Perhaps you could tell the committee how many or what precise percentage of the clients have been resettled and how many is left, and what's your plans for to get them settled or resettled to the way everybody wants.
So the remaining number will be resettled as soon as possible.
Do you know what that number is?
The Health and Social Care Board are kind of finalising the number at the minute. My sense was it would be between 20 to 30 individuals, but there's still work to finalise that number.
And have those people that have already been resettled, have they been resettled and are happy and content in their new surroundings? Because I know that there were a lot of concerns about people may have been forced out of Muckamore to somewhere they didn't want to go, and we had an assurance here on more than one occasion that that wouldn't happen, that the people that wanted to remain in Muckamore as their permanent home, that would happen while they were still there. But what's the situation in that regard?
So as far as I know, there are no issues with those who've been moved. I don't know whether my colleagues know more than me, but certainly we could write to you of any further detail we have about the status of people who've been moved and whether they're happy with the care that they're now receiving.
Yeah, well, that would be important, but it is vital that those that remain, they're not going to be pushed out somewhere against their will because you have a target date of March 2015. This was always my concern, certainly the committee's concern, that would happen. But if you can let us know how many is remaining and, how long is it going to take them to be resettled properly.
Yep.
We don't want to be pushing them out to somewhere where they don't want to go, something like that.
Absolutely. Okay.
I think to reassure you, Mr McCarthy, the HSBC is very clear now that there's a small remaining number of patients in this group for whom, for a variety of reasons, perhaps resettlement is either not suitable or more complex and they're now being looked at individual by individual. So I think these will include the group that you're concerned about.
Right, what can you let us know? Can you let the committee know exactly what the precise position is and a time frame perhaps? The other one is, what plans are there to address the structural underfunding of mental health services in general in Northern Ireland? Only today, and the lead, I think it was in the main news, where we had the psychiatric shortfall. The beds, there's not enough services there. Mental health services have always been regarded as a Cinderella of the health service, and all of your bosses have said, we want to put that right. Are you going to be able to put that right with the commissioning plans that you have in front of us here?
Certainly we've kept a target in the commissioning plan direction around access to mental health services because we continue to view it as critically important, and we're working with the Health and Social Care Board and indeed the Trust to try and ensure that target is met. Again, I don't know, Jennifer, if we've got anything specific in terms of the work that's going on.
Yeah, I know that the board has provided some additional funding to some of the trusts to build capacity in that area. I don't know the precise details of exactly how much it has been, but I can certainly...
Right, well, it would be very useful. Are you aware of the crisis that now in the psychiatric, where people just simply can't get beds?
No, we know... We're very aware that it's an area under pressure, and it's an area that both the board and the department are focusing on, and that we've kept in the commissioning plan direction, so that there is a focus on those targets and on delivering the service that should be provided.
Okay, right, Chair. Thank you.
Michael's next.
Okay, thanks, Chair. And just following up on that, in terms of learning disability patients, the deal was that nobody would have hospital as a permanent address by, I thought, now. So that looks like a target that you've missed. I assume you have plans or something to deal with that. I don't want to get into that. I thought Kieran made a number of very good points.
March, the Chair, Michael, was supposed to be, yep. Right,
the key thing was, in terms of mental health, was Bamford. Bamford rolled out in, I think it was 2010, taken through the executive. All parties signed up to it, and there's a number of recommendations coming out of Bamford. How many of those recommendations have been actioned so far? And how many have still to go, and where are we with that? Because that was the key. That's the blueprint for mental health services for the future. So where are we with Bamford in terms of mental health?
So I think the key thing has to be the resettlement into communities on which we've.
That's just one of the targets. There was a series. I can't remember how many targets there was. 28 or something like that. Yeah, maybe more.
We'd need to check on
we'd have to come back
understand
to you on
that. I know you're at a higher level. Let me get let's say, make other comments. Just no service developments. That's tragic. The way medicine and health provision is evolving, and we're not catching any of the new developments through new service developments. And I think that is a fundamental indictment of where we are and what we're about. The process, as I recollect, is there's so much money to spend. You have your commissioning plan, and you hand that plan over together with the money to the Health and Social Care Board. And the Health and Social Care Board delivered according to departmental ministerial priorities as determined here are illustrated at high level. The concern I have, and it's actually the point that Liam Donaldson raised with us last week, if you go to the Health and Care Board and you're giving them, what, $2.5 billion to buy health services, you're giving them $1 billion to buy social services, you're giving them money to buy health in the community. And as you know how this is done, so many HIPs, it's so much, so many heart, it's so much, so many domiciliary care packages at whatever the money is. But the actual tariffs, he was fairly scathing about how that was actually rolled out, that there didn't appear to be a uniformity across our trusts. There didn't appear to be, and it didn't seem to match the health service in general throughout the UK. He was, because when you hand over the money to the board goes to spend it, the board should know exactly what it's getting for its money, how many units of whatever service it's getting, it's ordering, that it gets it, that it's on time, on the money, the standards and all the rest of it. What are your plans to look at that to ensure, probably it wouldn't be in here, that the board appears to be, as I understand, appears to have dropped the ball in this area, that if Liam Donaldson is right, and that's very, very serious, because the board is actually the organisation, the body that spends the money for you. Isn't that right? And I don't know, what are they spending? Somewhere over $3 billion anyhow.
Certainly, yeah.
And if they ain't getting their tariffs right in terms of when they go to buy, even if they get it wrong by 0.5%, you know, so where are we with that?
So there's a number of points in there. One thing to say is obviously in response to the Donaldson recommendations, the Minister has announced a review of the commissioning process. So we'll look at the comments that Sir Liam Donaldson has made about complexity and scale in Northern Ireland and whether and how a commissioning process is appropriate. And we'll start work on that review soon. The other thing I think is to, within the year and when working on this, make the best of the process that we have. And this commissioning plan direction certainly has more of a focus on improvements in quality, productivity, efficiency and effectiveness. So we would expect even more of a focus from the board in demonstrating that value for money, demonstrating the unit costs. We'll be working with them on their detailed commissioning plan, which previously does set out kind of the units that they're buying and the price that they're buying them for. It may be that we need to increase the level of detail there in some of those areas in response to some of the comments from Sir Liam Donaldson. So we'll be working with the board to see how best we can respond to those comments within the current process that we have.
Yeah, because that's very important. That's about careful management of the resource, the money, which is the key ingredient here to make the whole thing tick. You can't simply go down with a check and say that, give that to the boys. Yeah. There has to be, okay. So when do you think we're going to see some daylight as in terms of that commissioning review? Presumably, Chair, we'll have the board up here and they can take us a wee bit further with this, but have you any idea when we're going to see?
So I think the Minister announced the review to be complete this summer.
So for the next commissioning plan, not this one?
Yes, correct, yeah.
Could I just then, I'll not keep you too long, but you are restating a number of targets. For example, outpatients, diagnostics, inpatients, cancer targets, A&E, ambulance, category A responses. And all of those are the ones that we've had for a number of years, isn't that right?
Right, yeah.
And you're restating them, and that's good. Where those targets are being missed, and a number of them now are being missed, and very, very seriously missed, and I see now cancer targets are on the slide. Do you plan to prioritise the money with the board to ensure that we get, for example, if you're waiting for cancer, and you're on a wait, I mean, patients come to harm, as you're aware, coming. So if you have urgent test at 14 days, 98% within 31 days for first treatment, or 95% within 62 days of patients urgently referred, if you're missing those and missing those substantially, then patients are coming down. Is there any strategic direction that you're getting will you target the money in those particular areas?
So in terms of the way the money is actually used,
Those
that's
targets are picked for a particular reason, as you know, 4 hours for
Absolutely.
any. There's a special reason for the 4 hours,
Yeah.
95% in 4 hours.
yeah,
You know, that's the key target, and these cancer, those are specially picked.
yeah, and we obviously monitor the performance against these targets, and we're working very closely with the board to try and improve that performance. I don't know if Fiona would
Yeah.
want to say a bit more about some of that work.
Sure. Just to pick up on the cancer-related targets, the board has been working over the last year to address the targets for breast cancer are reasonably close on performance, but in terms of the other cancers, they can be quite variable, trust to trust. So what the board did was it actually looked at the waiting lists by tumour groupings, took the 6 key tumour groups, the main tumour groups, which is upper GI, lower GI, urology, lungs, skin and obstetrics, and then got working teams together across all the trusts to look at where the best practice was, to share best practice and to try and bring a more consistent standard across. And certainly the provisional evidence on, for example, the 62-day path, which is the GP referral path, shows that all of those performance, for example, in urology, are all now coming into line together, so you're seeing a more consistent performance. And that's where the board is working at the moment. It's to bring the best standard of performance in across all the trusts, so to ensure that equality of access. And it's that approach rather than funding that's been taken.
Yeah, well, that's good, but funding has to, if funding ain't there, it's not going to happen. It's the funding's driving. So you'd anticipate getting them back to those targets?
Yeah, the board is monitoring, and it's pleased with the response and sees more improvement coming. It's also looking at, there's work being piloted in Wales at the moment that's maybe trying to be a bit more specific on the target pathways for individual tumour groups, maybe just to refine this a bit more. But they're doing a lot of work in this area because, as you say, these are exceptionally vulnerable patients.
Yeah. And just finally, Chair, the stroke strategy that's been rolled out, and you have 13% for thrombolysis. Is that lower than was originally planned by now, or higher? 13% doesn't ring a bell with me. I thought we were hoping to get a much higher uptake. We were talking about your stroke side. From April 2015, 13% of patients received thrombolysis.
Correct.
Should that not be higher? Or?
No, so one of the challenges with this particular form of treatment is that it isn't suitable for everyone.
Oh, you've got a screen or a scan, yeah.
So we've been, we've had to have a conversation with the medics, those people who are clinically qualified, to say, you know, what's a sensible level of target to aim for without incentivising behaviour that might actually cause people harm. So the target last year was 12%. We've upped that to 13% because we still think that is clinically reasonable.
What is it in Scotland, do you know? Because
I'm not even aware if Scotland have a target on this, but we could certainly check.
Yeah. Okay, that's great. Thanks very much.
Thank you, Michael. Paula?
Thank you. Earlier you had spoken about the targets that were altered from 2014 to now. I want to ask you specifically about 2 of those. One is the allied health professionals, and we know that treatment or to be access to allied health professionals was 9 weeks. That was the target. It's now been changed to 13 weeks. Do you see this as being an achievable target, or where did 13 weeks come from above 9 weeks?
Absolutely. Okay. So as with all these targets, we've looked at performance over the last year, how that looks. We've spoken to a range of experts within the department and without it at the board, for instance, to try and get a sense of what we think should be achievable by the system if it's working as effectively as it should be. Certainly the performance on access to allied health professionals has not been good over the last year. There would be an awful long way to get to the 9-week target. However, we think that there are things that the Trust could do to improve their performance, and certainly the board are working with them to do that, and 13 weeks should be an achievable target. I don't know whether there's anything else you want to say, Fiona, by way of context in terms of performance.
Just to say, we're moving it to 13 weeks because we want to see achievement, but we also recognise that there's a data problem in the background that we need to address and clean the data to get an accurate figure. So we are extending it out to 13 weeks, and that's seen very much as providing a period of time to do some housekeeping, make sure everything is calculated accurately, and I suppose our aspiration would be in the longer term, perhaps, to be able to revise that target back again.
Do we have any percentage of those that appointments that were met within the 9 weeks for the last year?
No, we don't have percentages. We don't, unfortunately. What we're seeing at the moment, and because there are data problems, the figures are very out of date and provisional, is we're seeing the number of people waiting increasing quite significantly.
Were many of those going over 13 weeks?
Over 13 weeks, I don't know. They're going over 9 weeks, certainly.
Do you see then 13 weeks as being unachievable?
But challenging. Certainly, it will be
Yeah.
hard for the health and social care sector to achieve that, but we think it's possible if they do everything that they need to do.
The other one is the outpatient appointments, and I know most of us will get queries through our offices to do with outpatient appointments. And again, that target has been changed. That it was 80% would wait no longer than 9 weeks. It's now down to 60%. Again, I take it you don't have any figures to substantiate why that has to change, or
Why it's
from last
changing?
year?
So, I mean, current performance is some way off the targets in the current commissioning plan direction. So it partly reflects the difficulties this year with lack of access to funding for buying additional capacity within the system. That obviously creates a backlog moving into the new year. And because of the financial position, there's a limited amount of external capacity that we can buy in for elective procedures from the private sector, which limits our ability to keep the targets up to the level they were at last year.
Yeah.
Again, I don't know whether there's anything
There is certainly.
detailed to say.
The waiting times for outpatient appointments are increasing. They're increasing for a number of factors. They increase naturally because the demand within the system exceeds capacity. That's the first issue. Normally, some of that excess demand would have been addressed by the independent sector. That isn't possible anymore. So those patients are building in the system.
Yeah.
That's one issue. The other issue that we have in the background is a natural increase in demand. And the third issue we have is that some of the trusts in certain key specialities are just failing to deliver their core capacity, that which the board has actually commissioned. And that can be through a range of reasons, including being able to retain clinical staff in a certain regional area. So the combination of all of those things and demand is building in the system, and we've seen a very significant increase in the numbers of people waiting this year for outpatient appointments.
What's the difference in first outpatient appointments and follow-up outpatient appointments when it comes to targets?
We don't hold the data at that. We're looking for that first outpatient appointment, so almost the triage point.
Yeah.
What we can see, and if I can be very clear with the committee, these are our performance figures. They're not our published figures. They're subject to change and data clarification. But what we've seen, for example, so far this year, for a comparison, say, for September 2013 to September 2014, we've seen the number of people waiting increase from just under 30,000 to 73,000. That's a very material jump. And we're seeing those delays right through the system. We're seeing delays in people waiting for a diagnostic test, but thankfully we're not seeing any delay in them waiting for that diagnostic test to be reported. It's waiting to get
on the
in.
list.
So it's a volume. So the board is working with the trusts to ensure that they get to their core capacity and to help them in every way to hit that core capacity. And we have to expect that the build that we've seen this year through the reduction in IS, independent sector appointments, that pressure will build again next year. So we're just trying to set more realistic targets, but keep targets tight.
It's extremely worrying when we start to, move the targets to a lot longer for patients, and because we know from, again, from coming in and out of all of our offices, where we have people who are coming in, where they're then gone over a year before they're finally getting diagnosis, because they've had to wait to go and see, they've had to wait for their first initial appointment, they've had to wait follow-up appointments, had to wait for radiography, they've had to wait for diagnostics, had to wait for AHPs, and it goes on and on and on and on. And, you know, a year down the line, they maybe still don't have a diagnosis. You know, so it's very worrying.
Yes, can I just come in? Thanks, Paula, for letting me in. Thank you, Chair. What's tight about a 60% target?
So I think when we're saying that, we're saying it will still be a very challenging target for the health and social care sector to meet. So what we've not done is reduce it to a level that we think will be easy for them to achieve, so that we can simply tick and say they've met their targets.
But isn't a 60% target poor?
A 60% target reflects what we know is their core capacity, and what we know are the number of patients waiting.
But what is it in reducing a target that incentivises or encourages the system to work better? Because you'll come back next year and say you met your target.
Well, so I think if we have a target that's clearly unachievable, there's no incentive for people in the system to work towards that, because they know they can't get there. What we need to set is targets that people find challenging, find difficult, have to work extremely hard to do, won't necessarily meet.
But what I'm suggesting you is a 60% figure is a poor figure in terms of achievement.
It's a poor figure if demand and capacity were balanced. Yes, if they were balanced. They're not balanced. Our demand exceeds our capacity. Therefore, the target that people will be seeing within 9 weeks, where demand and capacity are balanced, is the target. Where we now know that our demand outstrips our capacity, that target is unachievable. So we're trying to set a target that we believe is more achievable, and that will be trusts working at their capacity.
At their core capacity.
At their core capacity.
Yeah. But shouldn't there be a system whereby people are encouraged to work better to achieve a target? I mean, what worries me about shifting targets is that the problem appears to disappear when the problem still exists.
So I don't think we're trying to suggest by changing the target that there's no problem. We're not suggesting that we wouldn't like performance to be higher. What we're doing is setting a target that reflects the absolute best that we think can be achieved by the system by fully utilising the resources that we have. And it is that question of the resources that are available to us. If more funding becomes available in year, as with some of the other targets here, we may return to them and see if that would allow us to
But you're
raise
not,
the
you see,
target
because you've said earlier, you said the limited amount of money for elective care. So you've factored in now that you don't have the money for this.
Yeah.
You're not, you're agreeing at this point that there is limited money. So you're changing the targets. By next year, we'll be told you met your target. The patients will still have waited. 40% of them will have waited longer than we would have expected them to wait this year.
Absolutely. So the target is obviously about getting the best out of the system.
Yes, but it's almost a mirage. It didn't happen.
I mean, I certainly don't think that's what we're trying to achieve. I mean, the numbers are the numbers. You will be able to hold us to account on what's been
60% targets.
Well, and on the total
numbers. As opposed to 80% target.
The target is that 60% will be seen within 9 days, and nobody waits longer than 18.
9 weeks.
Sorry, 9 weeks. My apologies. And nobody waits longer than 18. That has moved from 80% within 9 and nobody longer than 15. But what we're saying is 60% within 9 weeks and nobody longer than 18. Hopefully reflects our system working well and at capacity.
Well, I just see goalposts changing. I understand what you're doing.
Yeah.
But in a perception issue and in your post-match analysis will come next year, it'll look like there was no problem if you meet your 60%.
I suppose if we look at from my point of view, I would suggest that if we look at these targets from the performance management role that I have within the department with the board and with the trusts, I want to see them working to achieve something. I don't want to be working with them with targets that are so far away from deliverable that they're a disincentive. I believe the targets that we've come to now are ones that the trust can focus on and hope to achieve, and that way we get the best. clinically out of the system.
Well, I think I would beg to differ. That's all.
Chair, that is an important point, just if I could just
Sorry,
brief-
Paul, are you
No, go ahead.
finished?
No, one more question to ask us.
9.9.13, and that's where we should be at, and that is slipping, and it's useful to recall that has slipped quite a bit in the last few years, and that is a barometer on the system, and it's purely down to the fact that there's not enough resource going into the health service to maintain the services required.
Paula?
Thank you, Chair. Just one final question. It's to do with district nursing. And we know that last year it was within the targets last year. I'm only assuming that those targets have been met, that it's not included this year.
That was the normative
Yeah.
staffing ranges. I think, again, because of the budget position, that hasn't progressed as far as we would have expected. So again, it's that issue about what realistically can be achieved within the resources available. And the district nursing, unfortunately, I don't think has progressed as far as we would have hoped.
So if it hasn't progressed, then why has it been
Shift.
taken out completely, or why?
Well, again, because of the available resources, I don't, the funding isn't available to progress the district nurse and normative staff and wages in district nursing as we would have expected.
Okay.
We have, in the commissioning plan direction itself, to sort of, if you like, to keep the focus on the application of normative staffing ranges, there is a requirement in the text of the commissioning plan direction itself, asking the board to demonstrate how it will sort of deliver the normative staffing ranges, and I think that's...
Yeah, so in that's part B, I think, isn't it? In the first paragraph there at the end of that, we talk about the plan setting out how progress will be made towards the delivering care framework, which is the framework which delivers
It
normative
is, it's
staffing.
the normative staffing ranges.
So we've not got the funding to set a particular target about how far we can get, but we have said we want the board to demonstrate how they can get as far as they possibly can within the overall context in which they're working on those issues.
Okay.
But,
Come back on, yeah.
Margaret, what you're telling us here today is that you've put 4 new targets in for acute, but you've deprioritised things like district nursing. You've removed that as a target.
So we can only put in targets that we can afford. Some of the new targets that we've put in are about saving money, or about the balance between say safety at the weekend or during the week, which we don't think requires new funding to achieve. It's just about the ways of working, whereas I think that the move to normative nursing does come with a price tag attached, which unfortunately there's not the funding
But
for.
then there has to be a process where you prioritise. And, you would prioritise on the basis of your strategic direction.
Correct.
And your strategic direction tells you we need to focus on primary community care.
Absolutely.
So, I don't think it would take a genius to work out that part of that is an increase in areas like health visitors, district nursing. So we have removed that as a target, and we have put 4 new ones in, which are about dealing with emergency departments.
They're not all dealing with emergency departments.
Well, they're dealing with acute care as opposed to community or primary.
Some of them are about stopping people going into acute care, aren't they?
Yeah, so there's a new target around dealing with acute conditions in the primary and community sector, trying to prevent hospital admissions. There is a patient safety one about death rates, and there's one around deficiencies in pharmacy.
But at what point, sorry, and this is about the strategic fit in all of this. So at what point then, or on what assessment, is it decided that a target that the Deputy Chair has asked the question didn't get as far as you had wanted to go? That's the only sense of it we have, but it's now removed.
What was the question?
What I'm saying is that there's been a target there in terms of nursing levels previously. It wasn't met, but it's been removed. So somebody somewhere made an assessment that comes out and something else goes in.
So we made an assessment that we couldn't afford to achieve that. in terms of some of the other targets, they may not have kind of specific new funding requirements associated with
Is
them.
the assessment always on the basis of affordability?
So the overall commissioning plan direction has to be affordable. But obviously there's...
We
you know, a
accept
range-
that, but, where does the strategic policy direction come in terms of an assessment?
So in deciding the total balance of the targets, and that's why we've got new targets here, which are about ensuring that there are less unplanned hospital admissions, so that more people are being dealt with in the community. That's why we've got targets that are around safety and around efficiencies. So what we've tried to do is focus the indicators that we have more on stopping people being admitted to hospital where they don't necessarily need to be in hospital, and making the savings within the system that will allow
But I
us
would
to
suggest, you Mark, with respect, part of that is around district nursing and the right levels of care in the community. Now, and I'll close on this, but has there therefore been, or is there an assessment of need? Does the department do an assessment of need before they set a commissioning plan?
Not the way the commissioning process works is the department will set key standards, and then need in terms of kind of population levels, etc., is then set through the board's commissioning process, working with the LCGs. So we will set standards for Northern Ireland, which we think are achievable, meet the need on a sort of broad regional level, are within our budget, and the board will then do more detailed assessments of what that means in terms of figures and quantums need in that sense for the different trusts.
Okay, but just, the department said one of the three targets this time around is improving and protecting population health and wellbeing and reducing health inequalities.
Yeah.
So where's the analysis then to say that on the basis of need and increasing health inequalities and levels of poverty, that doing X, Y and Z in the commissioning plan will have the right outcome? Where's that analysis? Who owns it? Who does it?
So there's not normally an individual analysis that underpins each commissioning plan direction. We would rely on, for instance, the analysis provided in Transforming Your Care, or in the recent Donaldson report, or other pieces of ongoing work that happen for and without the department.
Okay. There's a number of other people waiting. Mickey?
Yeah, my question is around the integrated care partnerships, because obviously that was one of the main planks of transforming your care to ensure that pressure was taken off the acute sector. Yet the targets relating to integrated care partnerships has been removed, and last year I think the target was 95% of people, frail elderly, who go into that category: frail elderly, arthritis, diabetes, respiratory problems, that they should be placed on that care pathway. I'm just wondering, have those targets been achieved? Because if you don't have integrated care partnerships, then you can't set targets for them. And I know in my own constituency, we were told in Newry there was going to be an integrated care centre. 3.5 years ago, Mr. Poots told us £50 million had been set aside, and I think 59 million for Lisburn. We haven't seen that happening. So if the idea is to take the pressure off the acute sector, and you've talked about care in the community, particularly in terms of primary care, that simply hasn't happened. And yet you've taken the targets out of the Commission Service Plan. Was even last year's targets achieved, that 95%? What is going to happen as we go along and integrated care partnerships are not in place? It's going to just put more and more pressure in the acute sector.
So we still support integrated care partnerships, and we think they're doing very good work. In terms of whether the 95% figure will be achieved, certainly the ICPs have done good work. The identification of the relevant patients, that work has largely been complete, and they're working with GPs and others to work through putting them on the care pathways. I don't know if we've got current figures on progress,
I don't think we have sort of precise figures. Certainly progress has been good, and I think that the target for this year has been very much a sort of process type target to ensure that ICPs are up and running. Certainly the indications are from the board that good progress is being made. What we intended to do this year is to try and monitor the impact and the outcomes of those ICPs. So, for example, there's the target on trying to reduce unplanned admissions to hospital for people with long-term conditions, which is an indication of how well ICPs are working. Also, we will continue to monitor the number of people being managed through the indicators of performance direction. Certainly that's the intention, is to try and to keep monitoring that through that.
Do you have any information on where the ACPs are actually in situ at this point in time?
So all 17 ICPs have been established that were proposed.
Well, they were proposed, but I mean, there's one in your area supposed to be one of those 17. That hasn't been established.
An integrated care partnership.
The actual centre. You know, obviously the partnerships may have been there, yes. But if you don't have the actual facility, because we were told all the allied health professionals, and they've been mentioned already, we're going to be under that one roof to take pressure. I mean, for instance, we were told that minor foot surgery, there'd be podiatrists, there'd be all sorts of specialist professionals there. But, you know, you can have the partnership in theory, but if you don't have the facilities in practice, then it's quite difficult to ensure that they're going to work.
Absolutely. So I think the partnership itself is established. In terms of the building of the new primary care centres in Lisbon and Newry, is it? I don't know if we've got an update on where those are. Certainly, I understand that they are progressing at the rate that would be expected. But we could probably write to you with a more detailed update on when you would expect to see those centres completed.
Thank you.
Thank you, Maggie. Rosie?
Very much, and thanks for the presentation. Can I say, just on a general note, that the way the whole way the plan is designed, it might be more useful if it was focused on health needs and desired health outcomes rather than departmental needs and making the department look good. It sounds like that to me. So if something happens, like for instance, could you not set realistic waiting times that are within health needs that are reasonable, realisable and practical, but mostly focused on health needs. So if you said it's 8 weeks is long enough to have to wait, and just deal with the fact that you can't meet that, but it's an honest picture, rather than move the goalposts so that you're still looking good to the general public out there, and it's only if somebody digs deeper that they actually see what the picture is. But would it not be better, more honest, just to deal with the honest picture, that this is what we think people should have to wait, but this is all we're capable of achieving at this time?
So obviously this is part of the commissioning process. So what we're trying to do is set the framework for the services that we think we can buy, which is why the targets are as they are. They need to be kind of best that we can achieve within the quantum of money in the system that we've got. So it's about buying those services off the system, if you see what I mean. That's why it's not set as it's something that we'd like to be the case. If kind of money were no object, it's about setting out what the system needs to achieve with the quantum of money that it's got, which is why the targets are set as they are. Certainly, we could think further on whether there's more we could say about kind of clinical best practice and the like. I know there are kind of separate quality standards set out for care in various places, which are more focused on that issue. Care being the best that it can be. This is a slightly different process focused on effectively sort of buying services.
Yeah, but I mean, I think you can still buy services, but just be honest about what actually is the outcome.
I mean, if we were to just set in this kind of what we would ultimately like to be the case, none of which may be achievable within the financial constraints, then essentially that leaves it to the board to then prioritise within that, because if it can't meet any of the targets, it's then entirely for the board how it prioritises how far it can get against each of those targets. So that's why it's important for us to set targets which the board can meet, but which is still challenging for it, because then that sets the prioritisation within the system and the balance between different areas. I think if we just set broad ambitions, then we don't end up influencing the way the board buys services, if that makes sense.
I'm not too sure I'm having my question answered properly, because I think the focus should be on health needs.
Perhaps if I could add, I understand what you're saying. You're saying that
There's something,
But these targets should be what people understand are there.
Dishonest, and I'm not accusing anybody of being dishonest, but the way it's set up, there's something inherently dishonest.
I think what Mark's trying to explain is these are not the targets that we are setting specifically as what we would like the public to achieve. These are the parameters that we're setting with the HSCB board as to where we believe, given the limited amount of money that we can provide, they should deliver a good service to. So you're absolutely right. They're not. What we would say to the public is, yes, we would like you to be seen at, within this amount of time, this amount of time, and this amount of time. At these stages, absolutely, that's what you'd like to be able to say to the public. But in terms of buying a service from the board, what we're saying is, this is where we expect you to get to, because we recognise we're not giving you all the resources that you require to deliver a service to meet the demand, to match capacity. But this is what we consider is the right standard of service. It is that kind of, there's two sides to it. It's very difficult, and if they are, as they're understood by the public, I can understand your concern.
Okay, well, I'll just move on to one of the other questions that I have, and it's about one of the items removed from the target list about specialist drugs, and that had previously been on with the target of a person being on the course for the drugs within 3 months, and now that's dropped. Now, is that just dropped as a target and there's no target anymore, or could you have thought about maybe making it 6 months so that there's still a target to aim for? It's just been dropped off the list, so where does it sit really?
So it's still being monitored through the indicators of performance direction, so we'll still look at how long it's taking people to be given those drugs. I think we removed it principally on the basis that there's no additional funding available for new drugs that are recommended by NICE, so it's really about new drugs coming in and not being able to afford those. I think if additional funding was to be found or to be available within the year, we would probably again return to that target and see whether we could reinstate it in some way. But certainly our understanding is because of that lack of funding for the new drugs coming online, that's why we've taken it out. Is there anything else to add?
Just like you say, that the intention would be to keep that under review and to, like you say, look at whether, when the funding, if should more funding become available for that, whether it would be appropriate maybe to set a target at 6 months rather than 3. But it would be a matter of keeping that under review.
So it is as bad as can be. It really is. The drugs just aren't going to be forthcoming, really.
Those specific described conditions for which there was a target that you would receive the drugs beyond the pathway within fixed. To date, the performance data, again, it's performance data, it's not validated, but the performance data shows that everybody was meeting within that target. The question is, when you're under pressure at a budgetary level for drugs, to carry it for one particular set of drugs, we need to make that balanced across everything. But it doesn't mean that the drugs won't be available.
Sounds like that to me, though.
So
when you say then, does that mean they will be available?
So the existing drugs that are being prescribed will continue
Just
to
To be available,
It
it's
might
just not within 3 months.
Right, but you don't know when. Could be 5 years, really, because you just don't know when.
I mean, we expect performance on existing drugs to maintain close to that level. I think it is the kind of difficulties with new drugs that NICE is prescribing. It's not clear how we would fund and support those, how long it would take to get people on those new drugs that are coming in. So that's the challenge in setting a target for some drugs, but not new drugs, if you see what I mean. So that's why we've not set a particular target against it, but we'll continue to monitor it through the indicators of performance because of that difficulty in distinguishing between kind of the existing drugs that people are on and new drugs that may be recommended by NICE.
Okay, I'm just coming from the point of view of someone who was heartened by that target and now maybe waiting for that specialist drug, doesn't know when they're going to get it, and that's the reality for someone who would have been, heartened.
Yes, but that was a specialist drug for a number of very specific conditions.
Yes, but for those people,
Yes.
saying that's their needs have dropped off the radar.
Well, I wouldn't say they've dropped off the radar. Certainly, as I kind of mentioned in the opening remarks, even where we've no longer set targets, we continue to monitor performance. Where we have concerns around where that performance is going, we'll engage with the Health and Social Care Board, the trusts, etc. So if we see performance really taking a dip in terms of the access to those drugs which are available, then we would work with the board and others to take action on that. So I don't want to leave you with the impression that kind of setting a target is the absolute be-all and end-all. We would still expect a good service to be provided to people in terms of access to those drugs.
If access, that remains an indicator of performance. So if access to for drugs for those conditions starts to fall, then that is something to be picked up and discussed.
Right.
What we're doing is removing a specific target for a specific group of drugs, because as Mark says, there are new drugs coming on all the time, and arguably then would be, in terms of equality for all, you should be adding and adding and adding to that list. That's it, but we will watch it, and if there appears to be any deterioration for those groups of patients, then it will be addressed.
Okay. Just one other question. Can I just ask about the Commission and Plan Direction, and in relation to the 30 targets, which of those are concerned with statutory spend and which relate to discretionary spend?
I don't think we've done that analysis. I think we probably need to take that one away and write back to you to give you an answer that we're absolutely confident in, if that's okay on that one.
Okay, thank you.
Yeah, I think it would be important to get that, Mark, because we had asked the Permanent Secretary a number of weeks ago as well to clarify where the discretionary spend would be spent. And I think in terms of budgetary planning, we need to know that.
Okay, yeah.
And we need to know on this how much is statutory and how much is discretionary.
Yep.
Okay, thank you, Rosie. Pam?
Thank you, Chair. Thank you. In relation to the links between the services that are commissioned and the 15-16 budget, can you tell me, has the department made a decision on how much to cut from the smaller arm's length bodies, and if they have, how much in total would that amount to?
So I don't think there's been a final decision yet on the administrative savings across the arm's length bodies. That work is still continuing within the department.
Okay.
Okay, Joanne?
Thank you, Chair. I'd like to start by focusing on the removal of the target for substance misuse services. Now, surely the Alcohol and Drugs Commissioning Framework 2013 to 2016 should have been published by now. And if I'm correct, the consultation ended in April 2013. So why is this being delayed?
Why is the target being removed?
Initially, and then around a bit more detail around the framework when the consultation ended in April 2013. Why has this been delayed?
The public health framework has been published. The consultation is complete, and that was published.
Well, why has a target been removed?
It's to the simple issue around funding and our ability to fund the level of that target. So as with all of these targets, we've had to think about whether we reduce the targets, remove the targets, and continue to track them through the indicated performance direction. And on this one, it was felt that there wasn't a significant enough quantum of money to develop the service in any way, and therefore that we couldn't set a meaningful target against that. But we should continue to monitor performance through the indicators of performance, and to kind of intervene if we see any particular deterioration in that service.
Again, reading through the 10 targets which were removed, it's very, very worrying. I see that's after specialist drugs, that's the second one on the list. It's just in a written answer in November, the Minister told me that the Health Board and the PHA were working on a procurement plan to tender for services, and that this had, and I quote in the answer, gone live, and that new service were to be in place by April 2015. Is this not now happening?
I think there are. I think there are new services in place. I think that there have been some developments against that target, but it's just, I think the extent to which the coverage has been rolled out isn't as we would have expected, and the funding isn't available to progress that any further.
Can you maybe provide me details of what's been rolled out? Because this is such an important issue, and as I say, I was told in November that it was gone live and it was been rolled out in April. Could you clarify that for me? Is it still going to be rolled out in April? Because there's, substance misuse, there's so many people affected by this, and I would be very, very concerned that would seem to, again, as Rosie had said earlier, fallen off the radar. So will you come back to me with details about that service? Okay. Again, the new targets, the 4 new targets for 2015. Reading through that, could you explain to me the rationale behind, I think it was target 25 regarding patient safety, that death rates of unplanned weekend admissions should not exceed the death rate of unplanned weekday admissions by more than 0.1 percentage points. To me, it just seems incredulous that this target exists at all. Where has a 0.1% come from?
At the minute, the death rate in hospitals is worse during the weekend than during
those admitted at the weekend.
For
those admitted.
Yeah, for those admitted at the weekend, the death rate is worse, and there may be a number of factors contributing to that. I think it's a phenomenon seen not just in the health service here, but more widely, and it will relate to the availability of doctors at the weekend and services and all of those factors. It's something that we've wanted to address. It's a key focus in terms of patient safety. So what we've done is looked at the death rate for the weekdays and the death rate for the weekend. There is a gap between them. I'm not sure whether the figures are public.
Where did you get the 0.1%?
So we've looked at the difference between the two and thought, how can we converge those? And 0.1% is a convergence in the two death rates. Again, we had the figures to provide. It would make it kind of slightly clearer. Are we able to provide them?
I mean, this is unplanned admissions for 2013-14. Again, as far as I know, these are provisional figures, but there's a 0.2% difference between the death rate of admissions.
So the weekend, there's a 3.2% death rate, and in a week it's a 3% death rate. We want to see that converge, so we said cut that gap, which is currently 0.2%, to 0.1%. And again, we would look at that next year and say, can we push for further convergence there?
It just seems to me very, very cold to have a target for death rates. That was, quite alarming to read that. One more point, if I may, Chair. Again, in the 4 new targets, in relation to new target 11, the minutes by which a patient should be triaged or assessed at an emergency department. I think there's a wee box and an X. Why has this target yet to be set?
So we're still combing through the data and checking A, that we've got data of the right quality, and then B, that would tell us what current performance is, and we could use that alongside clinical judgments to set a target which would be stretching but realistic, for the trust. So essentially, it's just while we work through some of the data issues on that one is why we've not yet been able to put a figure to it.
What would you expect the target minutes to be? What do you envisage this being?
We don't know yet. We thought there was. I'll give you an example of we don't know. We're trying to, as Mark says, it's understanding the data, and it's also understanding how robust the data is before we bring in a target. But the example I'll give you is we understood that in England it was a 15-minute target until when we looked at it in detail, we realised that was 15 minutes only for those arriving by ambulance. So that's a small part of the population visiting an emergency room. So 15 minutes isn't appropriate because patients arriving by ambulance are brought straight in. So we need to look at it, but obviously if we're convinced that the data is strong enough this year, we'll bring it in as a target. If not, the view is very, very keen to get the data cleaned up as quickly as possible and have it there, because it will provide an opportunity to provide an assurance that whilst people may have to wait to have their treatment completed at the emergency room, they will be seen and triaged and assessed for the urgency of their medical care within a very reasonable period of time, and that's very important.
So when will we know when this target has been set? Because you talked about for this year, we're going to have to wait to next year to find that.
So
I think it would be useful, Chair, to have the committee informed as soon as possible on this target. It's just, you're reading through it, seems incredulous that there's no time to put out.
We will be finalising there's a couple of gaps in here alongside that one. We'll be finalising that in the next few days.
Okay.
Very happy to write to the committee with the final position, filling in the 2 or 3 gaps that there are in the targets that we've shared with you. What we were keen to do was speak to the committee sooner rather than later. We were hoping to bring some final figures with us today, but we've not quite got to where we would have liked to have done with the analysis of those figures.
So we could be in a position to have those details with the committee next week then, if it's only going to take you a few days?
Potentially. So we need to finish the data work, check that the Minister is content with that position and finalising it, and then we would write to the committee off the back of that with the final information.
Look forward to receiving those.
Thank you, Joanne. Pam, you'd indicated, yeah?
Yes, Chair, sorry, thank you for letting me in again. It was just to ask about, I'm just reading down some of the list of targets that have been removed from the Minister's letter, and one of them is pressure ulcers. And I'll just read out to you what it says here. The current target requires a 10% reduction in present pressure ulcers across all adult inpatient wards. However, during the course of this year, it has become apparent that performance against the target is not being reported consistently across all trusts. During 15-16, the incidence of pressure ulcers will be monitored via the indicators of performance direction, with a view to resolving data quality issues and potentially reinstating a target for 16-17. So, would you spend 10 minutes trying to decipher that paragraph? Does that mean that the target wasn't met in the past?
So it means that the way the information was being reported was not consistent across trusts. Is that fair? So actually, it's very hard to tell. The performance data we got probably isn't true and fair and complete across the different trusts.
The process of clinical coding of incidents and stages of treatment within hospitals is extremely complex, and there can be differences in how things are recording, and sometimes we just have to go back to first principles and clean the data through again to establish a baseline. That's just the challenge of so many patients moving through a system, and all of the incidents that happen around them and all the treatments they receive being coded through in a way that we can understand in data.
So again, and the reason why that is, we're proposing that be included in the indicators of performance direction is to ensure that performance continues to be monitored, but at the same time to make sure that it's being reported and coded correctly.
And it may be once we've got a full year of data which we're happy and confident in, we could then set a target for future years with more confidence.
Is what you're saying?
Sorry, Pam, go ahead. Sorry.
Is what you're saying is that you're not actually happy with the results that came back?
No.
and they're being queried, and then the target's been removed because I'm not sure what to talk about this. I just think this is really serious. It's talking about pressure ulcers in hospitals. And it seems bizarre in 2015 that we can't collect that data.
Yeah.
And that the data is obviously differing from trust to trust, and it seems completely bizarre. Like, Northern Ireland's a small place. I don't understand why this is such a difficult target to report on.
There is a pressure within the health service here in relation to clinical coding. We are short of clinical coders. Clinical coders take 3 years to train, and then they have to work with clinicians for each patient to code in everything and agree those codings. It can then lead to anomalies because that's done by individuals. It can then lead to anomalies in the data that's recorded. Our statisticians and the board statisticians look at that. They can spot things that look incorrect, and that's what allows them to start to then they express concern about what they're saying if it's not been reported. The important thing for us is that we see accurate reports of pressure ulcers. So basically what we're doing is we're stepping back from a target into keeping an eye on it as indicative performing, putting the pressure on to clean it up and make it an accurate report. But it's important to say that the indicators of performance are really important because they are the more detailed characteristics that sit below each of these targets. You know, they are as from performance and for monitoring, for us they are as important as these headline targets that we're discussing today.
I'm very confused here. It seems to me that I don't know how you scrutinise these issues when you can't actually see anything from it.
Okay. Just wanted to come in on that on the back of what Pam was saying. I mean, I know because I worked in a hospital ward and I can actually see the bit of paperwork and the drawing and the photographs and the pressure ulcers and how they were monitored on the ward I worked on, and they were monitored very, very efficiently. So they were. So it's just how we have such discrepancies amongst trusts on how they record these and how they can't give that information over. And as Pam says, you know, the year 2015, surely by this stage we should all have the same. It should be the same generic paperwork across all trusts and same generic procedures across all trusts. And this shows us that definitely is not happening. And on the issue of pressure ulcers, are these people that come into hospital with pressure ulcers, or more worryingly, are these people who, because of their length of stay in hospital, it's resulted in pressure ulcers? Do we know, is there a difference or is it all one?
No, as far as I know, the target is aimed at hospital-acquired pressure ulcers.
That's even more worrying then.
But that's why we're continuing to monitor this. So it's not, no one's saying that by removing this as a target for this year that it's any less important. I think we all appreciate that it's a really key safety issue. And that's why it's there. That's why we're trying to focus on it. And it's just a matter of ensuring that we're getting accurate information, that we're, you know, that it's being monitored properly.
Well, I would definitely like to see the outcome of that, even again at the end of the year, to see what's being done on that, because I think that's extremely worrying that the trusts weren't able to provide that information on people who have received this because of the care that they've received, the pressure ulcers, while they've been, you know, patients in hospital beds. Very, very concerning.
Okay. Can I thank you, the three of you, for your attendance today?
Just one question.
Kieran, yes, go ahead. I'll be lenient.
Yeah, just finally, to what extent do the targets in the document Commission Plan Direction take account of increases in forecast demand and care and predicted health service inflation?
Yeah, absolutely. So that's kind of part of the process of us looking at the budget and then deciding that the total budget we've got, what we can reasonably set indicators for. So the draft budget process has included consideration of increases in population and demand alongside that, and we've then fed that into the process for setting these indicators. So they do certainly take account of that, and that's partly why it's so challenging to set some of these at the level that we would like.
Right, that's all right.
Okay, thank you. Okay, folks, thank you. I mean, I think most of the members today have requested further detail. I have to say, I find it concerning on the strategic point of the transfer to Transforming Your Care of the 2.5 million last year. You know, how we are supposed to encourage a policy shift that keeps people out of hospital on the basis of that money is beyond me. And I have to say, I've been really disappointed. I haven't heard anything on what you've said today in terms of a needs analysis. You know, that analysis, it should be the key starting point to direct commissioning. It just doesn't seem to be there. And, you know, I would go further to say, if we Googled Hansard, what we've heard today more times than enough is, I don't know, we don't know. You know, and I just don't think it's acceptable. This committee is, you know, attempting to scrutinise and deal with in the proper manner the commissioning plan, and we haven't had any of the detail that we require today.
There's certainly a lot of questions that...
Well, what I'm suggesting is that we submit our questions to the Minister and to the Department and have a written response to them. But certainly, I mean, I think all of the members today have asked questions which they didn't have answered. So thank you for your time today. Members, moving on to item 6 is the Firefighters Compensation Scheme Amendment Order 2015. Advising members that the SL1 was initially submitted in 2014. The rule has not, however, the rule was not delayed until 2015. The date and the amendment numbers have been reset. It's page 96 of the meeting pack for the relevant papers. Again, remind members that the committee considered and approved the SL1 for its rule at the meeting on the 14th of January. There was no changes, there have been no changes to policy content since the SL1 was submitted to the committee, and the Examiner of Statutory Rules has no issues to raise. Are members content, therefore, with the rule?
Agreed.
Okay, so the Committee for Health, Social Services and Public Safety has considered SR 2015 number 7, the Firefighters Compensation Scheme Order, and has no objection to the rule. Number 7 is another SR, the Firefighters Pension Scheme Amendment Order, page 111 of the meeting pack for the relevant papers. Again, reminding members that the committee considered and approved the SL1 for this rule at our meeting on the 14th of January 2015. There's been no changes to the policy content, and the Examiner of Statutory Rules has no issues to raise. Are members content with the statutory rule?
Content.
So the Committee for Health, Social Services and Public Safety has considered SR 2015 number 8, the Firefighters Pension Scheme Order, and has no objection to the rule. Right. Item 8 is SR 2015-9, the new Firefighters Pension Scheme Amendment Order, page 123 of your meeting pack for the relevant papers. Again, we had considered and approved the SL1 for the rule at our meeting on the 14th of January 2015. No changes to policy content, and the Examiner of Statutory Rules has no issues, so therefore are members content? The Committee for Health, Social Services and Public Safety has considered SR 2015 number 9, the new Firefighters Pension Scheme, and has no objection to the rule. Item 9 again is the new Firefighters Pension Scheme Amendment number 2 order, page 165 of your meeting pack. Again, we had considered and approved the SL1 on the 14th of January. No changes to policy content and no issues from the Examiner of Statutory Rules. Are members content with the statutory rule? The Committee for Health, Social Services and Public Safety has considered SR 2015 number 10, the new Firefighters Pension Scheme, and has no objection to the rule. Item 10 is the Firefighters Pension Scheme Amendment number 2 Order 2015. It's on page 174 of the meeting pack. Again, we had considered and approved the SL1 on the 14th of January. There's been no policy changes, and the Examiner of Statutory Rules has no issues to raise. Are members content? The Committee for Health, Social Services and Public Safety has considered SR 2015 number 11, the Firefighters Pension Scheme Amendment, and has no objection to the rule. Item 11 is the Health Service Workers Consequential Provisions Regulations 2015, page 184 of your meeting pack. Are members content that the department makes the statutory rule?
Agreed.
And item 12 is the forward work programme. I'm asking members to note.
Agreed.
Unless there are other issues. Item 13 on matters arising. There's one item under matters arising in the meeting folder. I'm suggesting that it's noted unless members advise otherwise.
Noted.
All right. Okay. Item 14 is correspondence. There are 13 items of correspondence in the meeting folder. I'm just going to draw attention to several of them. Page 14.2, item 14.2 on page 205 is a letter from the Minister regarding the Mental Capacity Bill. The analysis of the public consultation has now been published by the Department of Health and the Department of Justice. And as members know, a joint ad hoc committee will be set up to deal with the bill. At the moment, the department are indicating that they're planning to seek executive approval for the bill in March, which would mean the earliest it would be introduced would be April. Just advising members that myself and the Deputy Chair met with the Chair and Deputy Chair of the Justice Committee just a few days ago to discuss the arrangements. The composition of the joint ad hoc committee will be considered now by the party whips near the time as it's been set up. The intention is that the joint ad hoc committee will be briefed on the outcome of the consultation by both departments prior to the bill being introduced. That's for members' information. Item 14.11 on page 374 is a letter from the Royal College of General Practitioners requesting sponsorship for an event in the Long Gallery to launch LGBT guidelines for general practitioners. Are members content to sponsor?
Agreed. Yep.
And item 14.12 on 376 is a request from Action for Children to attend the next stakeholder event. Members content? Page 377 is correspondence from a Mr Larmour regarding changes to legislation around child protection. I'm suggesting the committee write to Mr Larmour advising him to contact his local representatives for support and advice on this.
Great.
Item 15 is any other business. Do members have any other business? And item 16 is date, time and place of next meeting, which is on Wednesday the 11th of February at 2 p.m. in room 29. Thank you, members.